Well, this is a large group of conditions, so I focus mainly on restless legs syndrome, which is a very common condition affecting around 10% of the population in Europe. Also, about 2 to 3% require treatment, so in some cases it's less severe. And in this case, an accurate clinical diagnosis is important. So the diagnosis is only based on the clinical assessment, but this needs to be accurate, and you need to, of course, to be aware of the diagnostic criteria. You can also have some supportive criteria, but the clinical part is the most important one. For other sleep-related movement disorders, you also need you can need video polysomnography confirmation, but these are more rare conditions. So the main focus also of my talk, I've touched briefly other sleep-related movement disorder, but was restless leg syndrome also because this is a neurological meeting, and any neurologist sees actually patients with restless leg syndrome because it's so common. For most of these minor sleep-related or more rare sleep-related movement disorder, unfortunately, we would still need much more data about treatment. There's no good guideline because just we do not have any good clinical trials assessing treatment. But there are discordant results. There is some other condition like nocturnal leg cramps is also part of this group of sleep-related movement disorder. And even in this common condition, we do not have enough good clinical trial for a best practice guideline. For what concerns restless leg syndrome, we have guidelines. There are still guidelines which are a bit older from the International RLS study group. There was a recent update at the end of last year by the American Academy of Sleep Medicine. And European guidelines are in preparation with the participation of different societies, including the European Academy of Neurology, the European Sleep Research Society, the European RLS Study Group, the European Pediatric Neurological Association, and the European MDS Society, European section, and also patient representative. And this is, however, a long process. It's ongoing because, of course, you need to review the current literature to make a recommendation. And we will try with these guidelines also, I'm involved in this preparation, also to provide good treatment algorithm for RLS and also to address a specific population. For example, people with kidney disease, because the incidence of RLS is more frequent there, or people with neurological condition like Parkinson's disease. The main change from the recent guidelines by the American Academy of Sleep Medicine was a conditional recommendation against all dopaminergic treatments. Also, practitioners are allowed to use this medication in case the patient poses more value on the short-term efficacy compared to long-term side effects. And the reason is that these medications are really effective, but on the long term, they are related to a very high risk of developing the so-called augmentation, which is a paradoxical worsening of symptoms related to treatment, so that patients have the feeling they always need to increase the dosage because the symptoms get worse, but actually increasing the dosage, the symptoms get even worse, and you have an improvement if you reduce the dose. And then it's a condition that it's really hard to treat, and it seems also that patients then respond less to different medications. So one of the main aims of treating RLS is also to avoid the development of augmentation.